For many couples, fertility conversations start with her, but often it's him who's quietly overlooked. In this episode, we're back with fertility specialist Dr. Becky Taylor, who explains why male fertility deserves just as much attention. From the genetics that influence embryo health to the lifestyle choices that can make or break conception.
From a male perspective, you can have genetic conditions which are going to cause low sperm counts. Motility can often very related to lifestyle changes. It's perfectly feasible. You see, really poor sperm count, somebody who's got a high BMI, they've been smoking, they sit down all day at work.
Here's what we'll cover: how male age impacts fertility and child health, the role of DNA damage and lifestyle in sperm quality, why both partners should get checked early, and how doctors can plan for family alongside career goals.
The sad thing is when you see somebody sitting in your office at 40 with a low ovarian reserve and who's desperately wants to have a kid, whereas if people are talking about it in their 20s and they're like, let's freeze our eggs or make embryos or freeze sperm or whatever it is they want to do, at least knowing about it and having the option to do it.
For the ones that male or female that do not want kids and you have a long-term partner, please make sure that you are on the same page as them.
If you've ever assumed fertility is only a woman's issue or think you have time to figure it out later, this episode is for you. Now, let's get into it.
Hi everyone, welcome back to another installment of the Investing for Doctors podcast. I'm your host, Dr. B, and I am joined again by Dr. Becky Taylor at Genea today.
Hi, nice to be back.
Yes, welcome back. Previously, I think we talked about a lot of things on sort of female factor infertility. So I think this episode, let's talk about the men. But before we start, let's give a quick introduction about who you are.
So I'm Becky Taylor. I'm a gynecologist and works fertility specialist as well at Genea. I did my medical training in Edinburgh. I'm originally from England and did my intern residency out there, and then came over to Australia and met my partner and just never ended up leaving. And so here is home now, and I've done all my ONG training over here. Love doing a podcast. So and
I remember you used to do a lot of teaching on the wards.
Yeah, that's right. Yeah. So always good for a chat whenever.
All right. So today's topic is we're gonna focus on the males.
Yeah.
What I've read is that in infertility, there's usually they broadly break it down to a third. A third is just female only, a third is male only, and a third is combined. Yeah. And so I guess there's a lot of conversation in women's health about fertility because that's seen as the biggest driver in fertility. But obviously the male side is there. I think there's not as much conversation about it because we're seeing 80-year-old men having children with 20-year-old models. So people think, you can be 80, you can still have a child. But my reading is that the age of the father is actually strongly correlated with neurodiversity and also other forms of diseases. Yeah. What is the take from the fertility specialist? Yeah,
well, look, I think it's good that you bring up the male side because I think it's very standard that, a lot of, patients will come through my doors and the female patient has had a full workup, they've done years up and the guy's not done anything yet, and it's always the woman assuming it's all her and and look, I think sometimes and I will say I always think it comes as more of a shock to the men when it's something on their side than it does to the men, because the women were always assuming it was them and the men were assuming it was all fine. Look, I think you're on the ball, on the mark there, that on the ball. That's
no, one ball.
Might need to edit.
No, we're keeping that
on the mark. Where male age does have an impact, and you're quite right. We do see high rates of autism and things in children born to older fathers, but certainly. lucky for men, they're not kind of on that tight timeline that women are in terms of ovarian reserve, because you continue to produce sperm.
Which could be a good thing and bad thing because, you're born with the eggs you have. So they're not really accruing genetic damage. They're just lower quality as you get older. But male sperm, because they're constantly going through that.
But I guess in the same sense, you've got opportunity to potentially adjust lifestyle factors. So, I think, when we're looking at male fertility workup, one of the key factors is doing semen analysis. I also, that will look at the sperm concentration, the motility, the sort of number of normal forms. We can also add in sperm antibodies, if you've had a testicular injury or surgery or, patients with previous vasectomies that we're reversing, you'll often see antibodies generated against the sperm, which can then impact on the ability to fertilize. And then one of the other things I always do from the offset is something called a DNA fragmentation index, which looks at the sort of amount of DNA damage to sperm. And certainly you can see in smokers, patients with very high BMIs, that you can see high level, the sperm counts might be fine, but the DNA damage is quite high. And sometimes I see that even in the absence of any define. I'm I don't know why. Everything's fine, but your DNA fragmentation index really high, you're healthy, you're in a normal weight. I don't know why. But certainly we see that DNA fragmentation index, if it's high, can have an impact on embryo development, miscarriage rates, etc.
Okay, so that does affect miscarriage.
So, probably the crux of the male fertility workup is obviously semen analysis. If you're going to do fertility treatment, we also, screen for hepatitis B, C, HIV, syphilis, gonorrhea, chlamydia screen. Also, not necessarily something that people would do always in advance, but when they come to my doors is I'll do a karyotype. If you've got a normal semen analysis, it would be unlikely for you to have any major whole chromosomal abnormalities, but there's always a risk of translocations.
Right.
So you might have a balanced reciprocal translocation where a bit of one chromosome is chipped off and sitting on top of another chromosome, and you have the right amount of genetic material, but when you make gametes and you sort of chucking out half the genetic material to make space for the eggs half to come in, you can end up in unbalanced situations. And so patients with translocations may be are more likely to have recurrent implantation failures, miscarriages.
Oh, okay.
Yeah.
And that's just basically in the male germline. And even though they could be a phenotypically normal male.
Yeah, absolutely. Yeah. So, so you can see it you can have female, you have balanced reciprocal translocation, or you have a male, but it will play into the fact that then your gamete, you're more likely to have, as you get, as a female ages, the eggs become less quality, you're more likely to have unbalanced, I guess you create unbalanced embryos that are chromosomally aneuploid. But equally, if you've got a male translocation, you're also likely to end up with an unbalanced situation because you're just not putting the right amount of material in. Yeah.
And so, when we look at miscarriages, for instance, because you brought this topic up, is a lot of sort of miscarriages due to these sort of things? Or
so certainly I think a large proportion of miscarriages are to do with a chromosomally abnormal embryo, but I would say the majority of those occur in patients who are have normal karyotypes. They have a normal chromosomal makeup. It's just that, in the inherent errors that occur in the mixing and matching, at fertilization, you end up with an unbalanced complement. Yeah. But if you, if you had a translocation and, you can, with a translocation, it is possible that everything ends up in the right spot and you end up with a balanced embryo. But statistically, you're more likely to, aside from then the female age factor, which, increases the rate of chromosomal abnormalities as you get older, you're then also throwing in, a lot of those sperm are going to be coming in with an abnormal chromosomal complement. Yeah. And so you're more likely to have, chromosomal errors. And so one of the things that we, will do for patients with a reciprocal translocation is we'll say, well, look, let's do IVF. Mm-hmm. And then we screen the embryos because, sometimes these patients might, they might be fertilizing an embryo or creating an embryo each month, but it's just chromosome abnormal as an implant. And so what you can do is, you can't change what the embryos are, but you test them and then you sort of, say they make 10 embryos, you select out the ones that then have a balanced complement and then put that embryo back. Oh, that's cool. So yeah, PGTSR, sort of free implantation genetic testing for structural rearrangements. Yeah.
Okay.
Yeah.
All right. Yeah, that's something I hear
Yeah. So it's like, and it's not like that, like it's not that common.
Yeah.
But it's not like in a fertility setting, like I'll see, a few cases a year.
Yeah. I mean, as a generalist, like, not even realize.
And but people would be like phenotypically normal, right?
Yeah.
So there's no like reason that, potentially, and look, and there's probably, patients out there that have translocations that have been able to conceive and don't even know that they have it. But it's like, it's not a kind of common, like it's not, most patients that walk through my door do not have, the reason they're not conceiving, but it's always something you would check with a karyotype because it certainly explains things if that's the case. Yeah.
Okay. So it sounds like there's, from the male side, there is going to be multiple causes. There's there's the obstructive where they're basically just shooting blanks, more or less. And there's the ones where they have poor sperm quality for whatever reason, whether it's genetic or environmental. Is there anything sort of else in that sort of male infertility side?
Look, I mean, I guess, like you can have genetic conditions which are going to cause like, low sperm counts, like something like Klinefelter's. Those patients may have like azoospermia or very low sperm counts, and we may be able to like find sperm, on a testicular sort of biopsy or aspiration. Sometimes, I often sort of think about like the concentration is often more reflective of something like, inherent that's like that sort of is pre-existing, whereas like motility can often like very related to like lifestyle changes. So, you can see like it's perfectly feasible. You like see, really poor sperm count, somebody who's got a higher BMI, they've been smoking, they sit down all day at work.
Sitting down.
Yeah, or they're like cycling to, 1,000 kilometers a week or something, and then you change those lifestyle factors and actually, you've kind of got to give a bit of time for the sperm because, sperm dropped in about 3 months, but they make some big lifestyle changes and then they really improve their sperm counts. And then there are other patients that have, conditions where it's not going to alter things. Yeah.
So you mentioned there was the biopsies and the aspirations. Describe what that.
Yeah, well, look, there's a few. I mean, look, with as your sperm concentration, like counts get lower or like your motility is very poor, the chances of like natural conception reduce. Even, sometimes if the concentration is a little bit low, you might consider intrauterine insemination if there's like, for example, female ovulatory dysfunction that you might overcome using like, letrozole or something. But as the sperm counts get lower and lower, the chances of like natural conception, diminish significantly. If we're able to find sperm, we've got such great like, scientists and embryologists now that if we can find sperm in the ejaculate most of the time, you can kind of use that sperm. And then if the concentration's low or motility is very poor, they'll do a process called ICSI to fertilize the eggs where they actually inject the head of the sperm into the egg to allow it to fertilize it rather than like, a sperm with poor motility kind of like making it sort of try and get its way through the shell of the egg. You're sort of kind of giving it a helping hand and putting it where it needs to be. And that can certainly like significantly increase, fertilization rates for those sort of abnormal sperm count like situations. So often like even with low counts, we don't need to do, any sticking needles into balls, essentially. Reasons we might stick needles into balls, if we can't find any sperm on the ejaculate. And so sometimes you might do like a teasy where you sort of under, general anesthetic, basically, try and aspirate sperm from the testes. Or sometimes if, we can't find sperm on that, then sort of doing what we call a microteasy where, it's not something I do, but some of the other specialists are sort of trained in that. You sort of actually sort of open up the testis and try and find sperm at the source. That's, obviously once you get to that point, there's still a chance you might not find anything. The other time, sometimes we might think about doing a testicular aspiration is like if you have a very high DNA fragmentation index and you haven't been able to prove that with antioxidants. And sometimes if you, get the sperm at the source, rather than from the ejaculate, they might have less DNA damage has been done to them at that early point. And so sometimes that can help improve fertilization rates. Yeah.
I've even heard from actually no embryologist, and he said this idea of people holding in their sperm is actually really bad because when you because there's a natural process, there's a lot of
Yeah, well, that's what we say, like, so patients that come to me with like a high DNA fragmentation index, I'll often say, look, go on a whole host of antioxidants, CoQ10, vitamin E, vitamin C, etc., and zinc, and then also, frequent ejaculation, like every sort of 3 days, because it's not good for the sperm.
Every 3 days.
It's not good for the sperm to be sitting there, for weeks on end.
Weeks on end. Yeah. There you have it. We have
make of that what you will.
Yeah, make that what we will. Yeah. No, because I've actually, what he said was, there's all these guys who just have no idea that, every month they're saving it for that day where it's, their wife's ovulating and then they go and they got terrible sperm quality. Yeah. But like, if they just like have a wank a few days before that, and it's like good quality, apparently.
And then the other thing that I often see is the sperm that, like, the semen analysis is done in some external lab, and then the sperm goes on a bit of a drive around Sydney for a few hours, and by the time it gets to the lab, it's looking a bit sad.
Yeah.
And so, like, often I have patients that come through and I'm like, oh, well, like, sperm count's a bit off, and then we'll, like, I mean, obviously if there's no sperm, there's no sperm. No matter how many times it drives around Sydney, there's just no sperm. Yeah. But sometimes I'll say, okay, well, we'll come and do it at a lab where, like, literally you give the sample on site and then it's analysed.
Also, do they not do that at the lab?
Well, sometimes you can do like a home collect and then drop it off. And if you drop it off an external lab and it's going to like make its way all the way to a central lab, like a drive around Sydney on a hot day for a few hours is probably not the best thing for the sperm motility. Whereas, so sometimes I'll have patients that had like an external result that was a bit abnormal and they'll come to Genea's andrology lab, do a sample there and it's like all fine. And that's the big thing I'll say about sperm. I mean, obviously if you've got like absolutely no sperm, there's something definitely not right there. But like low counts, like, there's a lot of patients that they're identifiable lifestyle like issues, like you're wearing too tight underwear, you're sitting on the bike for like hours in the day, you're sitting down all day, trying to kind of modify those risk factors can actually make quite a big difference. I guess what I see though is that, like, by the time people come to my office, they want to be having a baby now, so they're not super keen to then like go off and see if, like, they'll try and make the changes, but they're like, I don't want to wait 3 months to see if it made a difference when it might not do. So they kind of,
Now that raises an interesting question, right? Is that because the quality of the embryo is, or a baby, like, for instance, you're talking about DNA fragmentation. So, like, if a man was, trying to have a child, shouldn't they already like quit the smoking and wear less tight underwear and do or like have the antioxidants before that to optimize?
I think optimizing, and I think that's a key point is,
with the
females are like, I'm like thinking about having a baby, like I'll go to see my GP, and my pap smears are up to date, like I'm Rubella and like varicella immune, get on the pregnancy multivitamin, and the guy's just like, I'm here ready for you when you're ready to go. But actually, like, it's like lifestyle does play a huge
men should be doing that as well.
Impact. And I think, I think people are always a bit like, well, like, I don't really want to do a semen analysis unless I really need to. And so they kind of like leave it like, it's like, oh, well, that's the last thing that we'll do as part of, but maybe it should be something that people do earlier, because sometimes you have surprises, right? And, I don't know, it depends how you feel about things. But like, some people want to go, well, we'll just try naturally and see what happens. If there's any issues, we'll do investigations with other people. And I think a lot of doctors, probably a bit type A, are like, let's just investigate everything in advance. Yeah. And so I guess if you're thinking about it, there's no harm in doing a sperm count.
I've done it before.
It's not that. I mean, look, I'm going to say nothing's ever happened to anybody and like, give me a sperm sample, but it's like, it's not a big deal. So, and, there's a lot of options to do like home collect and drop off and things like that. So, and I mean, there are like I generally will get people to go to the lab at Genea, but like there are like, at home, like tests I believe you can order to do at home. So
I did it at a lab and it was a bit awkward, but like, not the most crazy thing I've done. And
like probably it's going to be fine, but if it's not, and it's like identifiable things you can change, then you change those. If suddenly you've got like a really low, what I often find with patients is they do an investigation and it comes back as like a total curveball. They were just doing it to kind of reassure themselves that they were going to get off things for a little bit longer, and that comes back as a complete not what they were wanting. And that's super distressing, but I'm always like, well, acknowledge this power. At least you know that now and not like in 10 years' time. Yeah. So let's, investigate and sort of modify any factors and then, talk about treatment options if it's sort of, And
again, we go back to that proactivity, right? It's just like, pregnancies are so precious these days. that, I mean, every pregnancy is precious, but like, you know, I remember my great grandparents who I met as a child, they were like, they would rank my grandparents and grand aunts and grand uncle, and then there'll be like number, there'll be missing one here, there'll be one missing there, and then it's just a different vibe back in those days. But now, like, everything is so precious, we should be almost optimizing everything, because I mean, we are doctors, we're very type A, and want to make sure everything is done right, and get the male side sorted, get the female side sorted, and then you have a go. Now, we obviously have a lot of young doctor listeners, and you know, we talked about female and male. Now, you know, what would be I guess, you know, both you and I are on the other side now. We've both got children, and you know, I have to say, before I had children, I had no idea how having children would have affected me, and it, you know, literally changed my perspective on life and every sort of thing, because you know, what would your advice be for sort of, you know, our junior doctors that are starting their careers, and you know, some may have partners, some may not have partners, that are contemplating family, fertility, and all that sort of thing? I mean, maybe let's do it for the female doctors first, and then let's do it for the male doctors.
Well, I think you can kind of like put that together. I mean, you know, like, I think there's never a great time. Like, when you're a doctor and you're training, there's never a great time to have a baby. It's not like there's suddenly this like one thing where it all just becomes easier, and it's like, you know, because it's hard in training. It's like, and then you finish, and you're a consultant, and that's not like a great time either, because you might have rooms, or, you know, like, you know, so it's, like, there's never like that time where it's like, and I think we're always on this incessant treadmill as doctors, where you're like, we're going to get to the next step and the next step and the next step. And suddenly, like, you're in like PhD to postgrad, you're in your like late 30s, and you're like, okay, well, I'm like, you know, I'm sort of a consultant now. Still not necessarily a great time to have kids, but like, I'm kind of getting like older now, like, I need to think about it. And so I think thinking about it, like, you know, thinking about what your plans are in your 20s, like, do you want kids? Like, do you want the option of having kids? You definitely not want kids. Like, that's whatever it is that, you know, like, wherever your head's at. I think from a female perspective, you know, if you know, you're in your 20s, you know, like, having kids is not on your horizon at the moment, like, I would strongly consider egg freezing, because, you know, you don't know where life's going to take you, and you don't know what your fertility journey is going to be like. And as I said, probably in the previous episode, I sort of slightly changed my tune, and I'm like, you know what, if you're going to freeze your eggs, like, within reason, like, the sooner the better. You know, 6 months here, 6 months there is not going to make a difference. But, you know, freezing your eggs in your 20s is definitely just to be better than freezing your eggs in your 30s, and certainly better than freezing your eggs in your 40s. And, you know, like, if you do freeze your eggs in your 20s, you have a reasonable chance of success. Equally, you might not ever come to use them. From a male perspective, I think, you know, you don't have that time pressure on you. But, you know, it's not a bad idea to go and get a fertility workup, get a semen analysis, you know, check your karyotype, because you might find a surprise there that you weren't expecting. You know, and sometimes, you know, if you are in a relationship and you have a surprise result, you know, you might be like, okay, well, we weren't going to have kids for 5 years, but actually I've got a really low ovarian reserve, or, you know, we're going to have issues because the sperm count's poor. Like, let's think about starting now. And, you know, sometimes that might be a case of like embryo creation and not actually putting an embryo back.
It's all freezing the egg.
Yeah, freezing embryos. And so, look, we can always say, like, you know, so, I mean, from a fertility preservation option, you've got freezing your eggs, freezing your sperm. I mean, freezing sperm is a little bit different, because, like, say you freeze your sperm, but even then you come and do IVF 10 years later, if you've got a normal sperm count, I'm going to tell you I want to use your like fresh sperm rather than your frozen sperm. Yeah. Because like you sort of reduce the like counts a little bit when you warm it up.
Yeah.
So like, you know, 25-year-old sperm versus 35-year-old sperm, if the count's good, not much difference. But, you know, you never know what's going to happen. Like, you know, have an injury on the sporting field, or, you know, you get a torsion and you suddenly like lose a testicle. I mean, you know, things can happen, right? And so I guess, you know, like male fertility preservation is not as big a deal in a sense that you would just go give a sperm sample and freeze it. You don't have to go through any stimulation, like, you know, FSH, egg pickup or anything. Yeah. And then, you know, if you're with a partner and you know that you're going to want to have kids together in the future, then embryo creation is an option. Now, if you're talking about success rates, like embryo creation is going to give you a higher chance of having a baby because, as I probably alluded to in our last episode, you know, an egg does not maketh an embryo. Like, well, an egg does maketh an embryo, but one egg does not equate to one embryo necessarily. You know, so if you've got 10 eggs frozen, you might get 2 or 3 embryos from those eggs. Whereas if you've got 3 embryos stored, you know how your eggs did and your sperm did together, and you've kind of got, you know, 3 hopefully reasonable chances of success. If those embryos are chromosomally normal, you tested them, like each of those embryos would give you about a 50% live birth rate. You know, and putting it back. So, you know, embryos get you as far down the line as you can get before you actually put it back and see what happens. Now, 50% live birth rate, that means that 50% of it is not to do with the chromosomes, and it's to do with the receptivity of the lining of the womb, how the embryo falls at the embryo transfer, you know. And a lot of the things we don't understand about fertility are things about like the receptivity of the lining of the womb. So we have, you know, a lot of patients that, you know, have recurrent implantation failure in the absence of any, you know, definable cause, where we put, you know, multiple chromosomally normal embryos back and they don't fall pregnant. And there are some patients that we never get to the bottom of why that happens.
There are things. I think I've seen them testing for the microbiome.
And I think there'll be so much, NK cells, microbiome, you know, and I think it's hard to tease out sometimes, but like there will be a lot of, you know, again, like the individual, there'll be a lot of development in that sphere because it's probably the receptivity of the lining of the womb is something we don't really understand that well.
And I think one of the other exciting thing that I saw, and this is still in the animals, is that they managed to reprogram ovarian cells into ovaries. As in not ovaries, as in the ovum.
Yeah.
But that's obviously in animals, and we don't know what you know, what that looks like in humans.
Yeah.
But
I mean, who knows what
happens in 5 years?
Fertility will look like in 25 years' time.
Yeah. We might have an incubator. We don't even need to put the embryo in a woman anymore.
Yeah.
Because I've seen that lamb thing that they did on they basically got they incubated a lamb that was about halfway through gestation all the way to term.
Yeah.
In an artificial womb. I mean, who knows what happens? There's just so much in there, right? Okay,
But I just sort of going back to the embryo creation. I mean, you know, from a success rate, that's going to give you greatest chance of a baby compared to freezing eggs because you kind of know. You already, like, for example, you know, I've had a few patients that have done embryo creation cycles for fertility preservation, and I always say this to them, it can be a bit of a can of worms because you might suddenly find that you think you're just doing, you've got a good ovarian reserve, got a good sperm plan, and your embryology is really bad, and you only got 1 embryo to day 5 and it wasn't even suitable for freezing. And so sometimes you can kind of think you're just doing this preservation and actually uncover a problem. So you have to be prepared for that.
And then the other part that you have to be prepared for is that your partner may not be your partner.
Well, exactly. And that was the next thing I was going to come to, which is like when you make embryos for someone else, they belong to both of you. So you can't use them unless the other, like if you guys separate, you can't use those embryos unless the other person says you can. No, I'm not saying that no one's ever given permission to somebody to What
happens in that situation?
Well, I guess, I mean, ultimately, you know, you have to both give consent for the embryo to being transferred if it's made, you know.
But from a charity perspective, I mean, if they go, well, you know what, you go use it and
look,
I don't want to be involved or
I don't know. Probably one for the courts. I mean, look, I don't think it happens very often, but I always say to people, like, those embryos belong to both of you. You're not that sure about this person, or, you know, it was a bit of a joke, you know. You make sure this is the one that you want to, you know, because I think, you know, that's the reality. It's like if you do make a whole lot of embryos and then you don't, not with that patient, that partner, then are you in what situation are you in, you know, 5 days down the line? So,
or should you just freeze the eggs?
Yeah. So egg freezing is like the eggs are yours, yours, ladies. You can do with them what you want. You know, they don't belong to anyone else. But your chances of success using them are going to be lower compared to making embryos. So, you know, I think it just depends, like, where you are in your life. I mean, in terms of, like, attracting, like, cost and everything, sort of, I don't like the term social egg freezing because I think it sort of sounds like flippant, like I was doing it for, like, you know, social egg freezing. But I guess non-medically indicated egg freezing, where you're doing it for fertility preservation in the absence of, like, you know, a diagnosis of cancer or about to have, like, endometriosis surgery and, like, take out a huge endometrium, which is going to, you know, reduce your ovarian reserve. So I guess social egg freezing and like embryo creation for fertility preservation do not attract a Medicare rebate.
Oh, yeah.
And so embryo creation particularly is quite expensive because like with the egg freezing, obviously you sort of stop at the egg freezing part, whereas then you got to do all the lab stuff with the embryos and grow them and stuff. So, you know, it's not cheap. So yeah, like I think, you know, always, people come in and, you know, like there's a lot of companies out there that do offer, like, you know, some of the bigger companies seem to offer fertility benefits to employees. And so I've had a lot of, you know, people come through who've used those benefits, which I think is great that companies are, you know, offering that.
Yeah.
Not something I think
It's it's quite interesting that they are not just giving their, you know, executives or employees the option to have a child.
Well, it's interesting because I went
have time off.
Yeah, well, no, like, anyway, I think it's a good thing because I went to I did a talk at a bank a while ago, and they, you know, I was talking about how some companies, you know, offer fertility preservation, well, for fertility benefits. It's called just like, or reproductive health benefits. I don't know what they.
Yeah. It's like,
and it's like you can use it for like egg freezing or embryo freezing or having a baby, obstetric cover, antenatal care. So it's like, or, you know,
it's a benefit.
It's a benefit. It's a benefit for family creation. Like, so whether that's, you know, and I think that's you know, because the bank were like, oh, I'm a bit worried that like if HR put this in, it would be seen as like saying that like, you know, you can't have a baby if you work with us, and you should like, you know, like that you have to.
Like you have to deliver
the egg. Like you'll be. It's like, no, I think so. I think it's saying, look here. Like if it was me and I worked for a company, it was like, here. I mean, no, freeze your eggs. Yeah. Well, not freeze your eggs. Here's some money to freeze your eggs, freeze some embryos. You'll have a baby, whatever you want. I'd be like, that's amazing. Thanks very much. You know?
Yeah. I think they should just label that as enabling family.
Yeah.
Or it's just family planning benefits or whatever you want to call it. Yeah. And yeah. So there are companies doing that now.
Yeah, definitely. Like, I think like a lot, I think the impression has kind of come out of America. So, but like, you know, people who, you know, work for American companies, there seem to be like fertility benefits that come with a lot of those companies. And whether that kind of translates into like Australian companies, I don't know. But when I started seeing patients, I was like, oh, this is great. Like, you know, what a great thing that your company is like giving you money to like do fertility preservation. And like, you know, at the end of the day, like if you're 25 and you want to freeze your eggs, you know, you don't want to have a kid at the moment, like, but you're with that company and they're offering that benefit. Like, why not? Like, I think it's great. And I do think though, like, you know, that kind of comes around to, you know, I think sometimes people feel a bit awkward about having the conversation. Like, I think it's great that you bring this up because people are like, oh, I don't want to like seem like you can't, you know, if you do surgical training, you can't take any time off to have a baby, and people don't want to kind of like talk about it because they don't want to be seen as being like, all right, you've got to do this. But I think like as a female gynecologist, like I'm happy to stand up and say like, talk about it, think about it, because like the sad thing is when you see somebody sitting in your office at like, you know, 40 with like a low ovarian reserve and who's like desperately wants to have a kid. And there's only so much you can do at that point, you know. Whereas if people are like talking about it in the 20s and we're like, let's freeze our eggs or egg embryos or free sperm or whatever it is they want to do, at least knowing about it and having the option to do it, I think is.
And knowing the choices. And that's why we're here, right? And, you know, from my perspective, you know, we didn't really go through much of a fertility journey. It took a little while to get pregnant, but like we were still under 30s when we had our first child. And like I think after having my firstborn, it just changed how I viewed everything, because before then medicine was everything. And now you have this other thing which gives you purpose. And I almost tell people these days that, you know, I think having a child is one of those things that will give you almost instant purpose, because you're like truly now responsible for someone else, and you know that child loves you unconditionally unless you ruin them. Okay, that's the thing, and it's such a beautiful thing, and to miss out on that, like I feel it's a huge shame in life, and
I think look, there's you know, I think to me, the biggest thing is about people being empowered to make the right choice for them. Like having children is not for everyone. But I think what's really heartbreaking is somebody who really, you know, when you see somebody and that they are older, there's like not as much, you know, we can do. Their chances of success are lower. And you think, God, I wish I'd seen you at like, I met you at 30 or, you know, and we could have had this conversation, or somebody at work had told you about it, you know, like egg freezing. And I think that's where I have like a lot of hope, is that I think the younger generation coming through, like whether it's because they're talking to each other or it's Instagram or TikTok or whatever, I don't know. But like, you know, I feel like I'm seeing like younger patients coming through, and I'm like, great. Like, you know, somebody the other day said to me, I feel like ridiculous. I'm like 20 in your office. And I was like, guys, this is great. Like, you know, because I can do a lot more at 20. Like your chances of success are a lot better at 20, you know, if we're doing egg freezing than if you're, you know, 40 for sure. Like,
I guess what triggered me to come to you and have this conversation is that there was actually a post in our group about this specific thing. And there were a lot more sort of senior clinicians that I sort of went through that journey. And I would say the unanimous sort of feedback from that is like, don't wait. The hospital will still be there. When you come back, you know, we're so short-staffed of you know, doctors these days that it's not a detriment to your career. Yes, it's going to be harder because everything's going to be harder when you have children. But if you want it, don't delay it because you never know what's going to happen at the other end. And like I remember reading those more than 100 comments on that post, and you know, there were a lot of people that posted anonymously because, you know, they don't want to be known. But yeah, I think the resounding comment was, don't wait.
And somebody said to me, I remember being, somebody saying to me, like, you know what, the hospital doesn't remember. And there's so many amazing doctors that have mentored me who are retired, and I will always remember them, and, you know, that I'm so grateful for. But, you know, the workplace as a whole doesn't remember it, you know, it wants you to come to work. It wants you to fill this, like, make sure the roster's filled. And you've got to, you know, you've got to take ownership of your, you know, you've got to put the time into yourself and make sure that you're addressing, you know, what you want as an individual. And that might be entirely career focused and not having kids, and that's totally fine. But as long as you kind of, you know, I think we're so lucky in this day and age that we've got options of fertility preservation. You know, look, I think, like I said, only 10% of patients worldwide have gone back to use their eggs. And so you might freeze your eggs and you're like, I just felt better having them frozen. I don't think I even want kids. But, like, I've got some eggs frozen. It makes me feel like I can kind of keep doing it residually. It's an insurance policy. I probably never use it, but, like, I've done it. I feel at peace with that now. And I think having that option, albeit it's never a guarantee, is good. But I think the one thing I'll say is, like, it's never a good time. Like, there's never a good time. There's always something jealous with time. There's always something else to do. There's always another, like, master's or PhD or research project or job or something. Like, it never ends, right?
Yeah. I actually had both of mine during when I was doing a PhD, and it was just like the best time ever.
And so I think you've got to just sometimes be like, well, you know what? Like, and I think it's hard, like, you know, as a female, you know, like, and you have time off, and you feel like you get behind your peers, and you know, the younger doctors that don't have kids, and they're, you know, they're sort of not coming to work tired, and they don't have to juggle everything at home. And you're like, oh, I remember those days I used to, like, you know, be like, oh, I can stay till midnight to watch this interesting case. Like, I don't have anywhere to be. Like, but, you know, partners at work anyways, or like on call or something. And you know, but I think you've got to just make sure that you look after your like personal aspirations, like outside of medicine, because medicine is not going to look after those for you. You know, you need to make sure that you're looking after those.
And also another thing that I want to put out there, you know, for the ones that say they're adamant, whether male or female, that do not want kids, and you have a long-term partner, please make sure that you are on the same page as them, because I've seen a few cases where, and this is often, you know, the men that say, I never want to have kids and I don't want to have kids. And then they speak to their female partner and they'll be like, oh, okay. But it didn't come from them. And that has ended up in disaster. So, like, you know, if you want to have children or if you don't want to have children and you have a partner, make sure you have conversation with them.
Yeah.
And I think that's probably the other thing I've learned, sort of speaking to people. Yeah. Because that's, if you don't want kids, but then they're not absolutely sure, you have to work that through. Otherwise, I've seen cases where people go back and regret.
Sure.
And, So, that's a bit of somber. And I think there's one thing that we forgot to even talk about and touch on is that in the modern family, it's not just male and female anymore. Yeah. So I guess the same principles apply for sort of same-sex couples.
Definitely. So I do a lot of donor work. So I have a lot of like same-sex female couples who are looking for sperm donors. There's known donation where you kind of, you know somebody who you want to be a sperm donor, and then I meet with them, or we work them up, do all the sperm analysis, etc., and then, make embryos. Like depending on like preferences, sometimes, you have same-sex couples where one individual is going to get the eggs, create the embryos, and then carry the pregnancy. There's embryo sharing where one of the one partner will give the eggs, they create the embryos with the donor sperm, and then the other. So many mutations. You got like same-sex male couples who might be looking for, an egg donor and then a surrogate.
How does that work in Australia?
So look, it's quite a messy from state to state in terms of legislation. So the thing, like I can only really speak well to New South Wales, because it is very patchy legislation. And I think there is a push for like a national registry of donors and kind of more, I guess, consistency, I guess, across the country. But essentially in New South Wales, like any kind of gamete donation, so it's egg, sperm or surrogacy, has to be altruistic. So you can't pay somebody you can cover the costs of their, gypsy over egg retrieval or, any medical costs associated with being worked up for sperm, donation, but you can't hand them over a check of, $10,000 for their eggs or the sperm.
Which happens obviously.
Same for surrogacy. You can use clinic recruited donors, and you do pay for those. So like, for example, at Genea, we were at the European Sperm Bank in Fairfax. So Fairfax in the States, European Sperm Bank in Denmark. And then there's like an in-house Genea donor. But it's quite like heavily legislated. There's a central donor, like New South Wales registry. So any children conceived from donor gametes are put onto that registry and then have access to sort of identifiable information about the donor from the age of 18. So I think the kind of aim is to be more open and transparent about that. And I do a lot of donor work, and I love that. It's really rewarding. But again, it's the same situation. The eggs do not age well, so it's still the same. The conversation. It's all about the a lot of it's also about sperm, but it's a lot about the eggs and the age. Yeah.
All right. Now, that sounds like a very good conclusion to our episode. Touch on everything we need to do, and again, the I guess the take-home message is, if you're thinking about it, get on top of it early. Don't wait till you're in the late 30s or 40s to
just have a conversation, and there's there are so many people I see that come and see me. We take history, do some investigations, and they're like, okay, don't want to do anything. And that's fine. But like, at least you kind of had that conversation and
that you're
explored that avenue. And, you've got to make the right decision for you. But I think what makes me sort of optimistic is that I think I don't remember anybody talking about any of this when I was in my 20s at med school in Scotland. But I wasn't thinking about it at all.
When I was in medical school, I don't think anyone's talking about it. And it's only as we've progressed, more and more people are talking about it, because I see a lot of my own colleagues going through that journey and having issues with fertility. And so I think those that have gone through that journey are now advising and sort of mentoring the younger generation of doctors and having that conversation. And I think that's vital as a profession and also as a species, I guess. Yeah.
Definitely.
Right.
I like it.
Lovely to have that conversation with you today.
It's been a pleasure. Thanks for having me.
Absolutely.
This podcast is for educational and entertainment purposes only. The information and opinions shared are not intended as personal financial advice. The content presented should not be relied upon for making financial investment or other decisions. Listeners are strongly encouraged to seek the advice of qualified financial or legal professionals before making any financial decisions. While we aim to provide valuable and accurate information, we make no guarantees regarding the completeness or accuracy of the content. Any reliance on the information provided is done at your own risk.